So without further ado, I'm going to go to the first questions. Dr. Belmarie, thank you so much for categorizing them for me. You made it a lot easier. So I'm going to go with the first question. Are we ready? And this one comes to you. So this is somebody who's just said, I'm in my late 40s. This is a female patient. I experienced fever, headache, tinnitus, body aches, fatigue, nausea recently, and a hospital GP suggested these might be premenopausal symptoms without conducting any tests. These symptoms have been intermittent for some time. I'd undergone blood tests before falling ill again and inquired about the results. The GPs didn't express any concerns and the results were mostly normal. Should I request any additional tests? If so, what test should I be looking at and consider asking for?
Okay, this is really a good question. So she's above 40, isn't it? So we exactly don't know the age, but so people can have in menopause starting anywhere between 45 to 55 as well, but average menopausal age in UK is about 51. Probably Vikram agree with me. And so this we call as a perimenopause, and this can last for a few years before even actually few people go on to actual menopause. So to diagnose menopause, we don't need any investigations. Actually, the clinical history is very important. So people in this age group, if they don't have periods for 12 months or more, so it's most likely is menopause. So they can have variety of the symptoms, though. Some of the symptoms are typical, like hot flushes and other features are very common, but some of them may not be. And that's why it can be sometimes very difficult to say somebody is going through perimenopause as well. But if the history is if it's typical, so they can be diagnosed without any test. But if it is not very clear, sometimes so the GPs or hospital doctors can do some tests to make sure that nothing else is going on with the patient. So because it's difficult for us to individually comment on because we don't know the patient's other history and things, but if the doctors who is looking after this patient is worried about any other things, they may do some tests. But actually, for menopause diagnosis, it's very difficult. Sometimes they can do the hormones like estrogen, LH, FSH, if it is not very clear, it's not coming into the particular definition. But if they are okay, that means it's fairly reassuring that they probably this patient is not going through menopause. But it has to be done 2 times, at least 2 times, because if the tests done are in one particular cycle, so next one they can pick up in the next cycle. So it's like 6 weeks or so. That probably will give a clear picture. If any doubt, so we can visit the GP again to discuss, to get some reassurance. If at least a couple of times in different periods, if the tests are okay, probably not going through perimenopause, but we'll look at other medical conditions.
Can you hear me? No?
Yeah.
Okay. I think that's great. And so this is, I don't know, this is not a question on here, but we touched on perimenopausal, but what should people expect in that phase exactly? Like, what are symptoms that they should start looking for too? And
okay, people with what we are talking about is the low estrogen, isn't it? That's what it is. So for some reason, it's naturally, or with the people with aging, so they ovarian function, ovaries lost function. So around the menopause age, that's why you're getting all the low estrogen symptoms. The other symptoms can be so many numerous. I will go through a few. For example, like a vasomotor symptoms, we call it as hot flushes or night sweats. So it can be there. And a lot of people can have it, but some of them may not have them as well. And sometimes people can have a muscle aches, low mood or anxiety. They can have low libido, memory problems, memory loss. Sometimes they can have a urinary symptoms, like a lot of people we see, they will be actually diagnosed with a urinary tract infection for a few years, but not getting any better. Ultimately, it comes to the menopause or perimenopause. So it is they're all low estrogen symptoms, if that's clear.
It is. Okay, so another question that's on here is in terms, so this talks about early menopause and tests, and they said, is mood affected by menopause, and are there any methods to prevent or alleviate its impact?
Is that for me again? Because
Yeah,
these
would that
questions can be equally answered by
Yeah.
Vikram. I think we
well,
taken the
we
questions
take a
because just to,
yeah.
I'll take that one then. So
okay.
so yes, so mood can be impacted by menopause, whether it's premature, early, or menopause after 45. Some women may predominantly have mood symptoms, so feeling very tearful time to time, feeling low mood, overall depressive thoughts. These tend to become more common as perimenopause and menopause happens. And there are a number of things that can be done. So it's usually a multi-pronged approach if it's the mood symptoms. So hormones can help somebody who hasn't previously been on hormones, and we think that these are mood fluctuations happening because of the hormone changes. HRT can be a good tool. Of course, there are non-hormonal methods, for example, considering psychological counseling at this time, as well as CBT, cognitive behavioral therapy, which is a form of psychological therapy that's quite popular now, which can help with mood symptoms. Antidepressants have a role in select group of patients. I won't say everyone needs antidepressants, because if it's because of hormones, you're more likely to benefit from not taking antidepressant. But certain women who may not wish to choose to take hormones or may have contraindications because of high-risk medical history may consider antidepressants as another option. So there are a few different ways you can approach mood symptoms, but they certainly can be just a part of the perimenopause and the menopause.
Okay. And the other question now, I think, Lakshmi, this is putting you in the limelight again. So this says, the Thal men receive testosterone injections because of low libido. Why can't us women also have testosterone treatment, which has proven highly effective for the effect, yet low libido in Thal women going through the change? I desperately want this and have asked to be referred to endocrine specialists, but I think it's fallen on deaf ears. I want to feel like a woman, and I don't anymore. It's been 5 years and I want to feel something.
Okay. It's again a great question. I think it's like testosterone is again, it's a natural hormone, even in women, so not necessarily men. So estrogen and testosterone, but so as in males, in female, the testosterone levels can go down with the time, and so people can have low testosterone symptoms, for example, like a low libido as well. This is one of the symptoms, but they can feel tired and they can have myalgias and things as well. But this is more pronounced in males compared to the females, because estrogen is the main hormone compared to testosterone. But so I think it is, the testosterone can be given in women, and but we would like to make sure that we treat appropriately with the estrogen replacement first before we can see whether, because a lot of the symptoms from estrogen deficiency can contribute to the testosterone symptoms to the testosterone deficiency. So we have to make sure that they are adequately replaced with the estrogen or progesterone or combination therapy the first, because a lot of symptoms can improve. A lot of people we see have not properly replaced first. So on top of that, then we have to make sure that we check testosterone levels if we want to treat a testosterone deficiency, but we have to check those tests first, and then we can discuss that. But not all of the healthcare professionals are kind of very well equipped to start this testosterone, because not very much advocated and things. But we have few people who are on testosterone replacement. But so we have to make sure that they're on adequately on HRT first, and they still need some treatment, testosterone replacement, they can have it alongside. But for that, then they need to make sure that there are no other causes, and also testosterone levels are not too high before they can be on have a testosterone replacement. It's not no or not completely. I think it's a matter of finding the, I think being referred, maybe you need a referral to the endocrine specialist or those specialists who can, menopause specialist like Vikram, who can deal with that situations. I think it's probably not many GPs are comfortable to deal with that because the risks associated with that once the treatment is there.
And, one thing I'll tell you about GPs, and I can, I think this is reflected throughout the Thal community, is that we don't tend to access GPs like I think other people without the condition is, because, this is in my experience, but from the time that the GP hears you have thalassemia and you're monitored by hematology, it's sort of like they sign you off to go there. So I think what I want to understand for our patients is in terms of if they're going through this, they're living in, say, Bristol or somewhere else where there's not a huge Thal population, what would you suggest that they do? Like, where thalassemia for GPs wouldn't be heard of, and people really don't want to touch you when you say you have thalassemia. But what do you think their course of action should be at that point? Should they speak to their hematologist to get referred to a bigger center, to with somebody with experience? What would you advise there?
So I think that's why, I think I'm sure, I hope Vikram also contribute later on. So that's why I think we have now thalassemia coordination centers where we get all the expertise together so that, ideally all thalassemia patients should access all these services, get access to these services. So to get a equal opportunity to have all the treatment. So, for example, in our center, if we have, when we deal with, we see the people with the thalassemia alongside the hematology colleagues because they know the patients more than anybody else. So when we address the endocrine problems, so we also look at the bone problems as well. So one part of that, we also look for the fertility issues, and also if somebody, a lot of people with thalassemia, so one of the most common endocrine problem is hypogonadism. So that's very, very important. That means similar to the premature menopause-like situation. So that means people have to be on HRT sooner than later, because that is the best time to protect bones, even to the sexual function, or a lot of other things, cardiovascular disease, that means to prevent the future heart problems and things, or memory problems in the future. So they have to be, as soon as they diagnose to have low hypogonadism, that means low sex hormones, either from the pituitary or from the ovary problems, either way, they should be on HRT, and should be usually young women require bigger doses than the elder counterpart. So they should be on effective HRT treatment to prevent all these things. So when we will discuss thing, and we try to monitor as well, so that means you need a service that can diagnose, treat, and monitor as well. So it may not be possible for all the level, but I think we're trying to do that whole north area. So we're trying to make sure that all the people with endocrine problems, at least, to be reviewed by us as well. At least not necessarily the non-dental review every time, maybe once in a year, or we can triage depending on that. People initially may take maybe 2 to 3 times a year, but after that, once we know them, so we can follow up every year or so. So I'm sure I think we are not there yet, but we have seen at least last 2 years or so a tremendous improvement in how we are kind of able to deal with this.
Okay, and just a word to our patients. If you are struggling with some of these things and you're not getting anywhere, you can contact us, and then we can help create those channels for you to get the right treatment as fast as possible. So please use us and tell us what you're going through. Dr. Balmarie, you're not off the hook yet, because I'm going to go back to the same question we just spoke about.
Yeah.
I think so. This woman spoke about having a low libido and not feeling anything. Are there other things that can probably help women and men who feel like, so if they're on conventional therapies and things, but are there anything else that you could suggest that might help them to increase this?
Yeah, so it is again multi-pronged approach, as Vikram said, to the other things, like similar to the mental health issues or psychiatric problems. So It is so most commonly the libido is low libido is associated problem rather than a male problem. It's the symptom of underlying cause. So if somebody is going through difficult thalassemia control or a lot of tests going on, frequent follow-ups, going through a lot of liver disease and things, so medication things. So these are all causes, people can have low libido with all these things because they're going through very, very challenging time. So this can cause anxiety and stress and things. So keeping themselves and looking after themselves is the first thing. First, to give them their own time to just to step back and to give their time. So that will probably change things. And also treating underlying cause like a better thalassemia control, that will improve the hormones if it is because of if it's causing low either estrogen or testosterone. And if it is if they have got hypogonadism and need HRT, they should be on a full HRT, so they may see actually get improvement itself. So, and anxiety and stress, so need to be again something like if they're going through low mood, depression, can be done by the again either CBT or talking therapy, psychologist. So it's like a low libido can be helpful from if we rule out all those things. Still, we think that there is a role for testosterone. That's only one of the treatment. We can help with that. Our GPs, I'm sure, the others will help that. But a lot of things comes before testosterone.
Okay.
In
Now,
that case, if somebody need a testosterone, so they can contact either through the thing that is the thing. They can directly they can discuss with the endocrinologist, face to face at one session, at least 1 or 2 sessions, really help them to going through what it is. So it's not easy, just to do that. So there must be a lot of things going on. Sometimes the reassurance itself may help.
So I wonder, because we've been speaking about menopause in women, shall we ask some questions about something tailored for men, or would you like to continue? And then we go through. My screen has changed.
Yeah, okay. Now you are back now.
Yeah, I am. Sorry. And yeah, or should we continue with the menopause and then we go on to mental
It's up to
health?
you, but I mean,
I feel like, because we have quite a lot of men in the
okay,
like signed
fine.
on, so I think we should take. So there's a question here in the chat, and it's, how do we deal with the side effects of testosterone, especially anger, short temper, but still keep the benefits?
Okay, that's a good question. I know this take long time. Normally, we take whole clinic session to deal with that. So I mean, it's good, at least I'm starting with. So testosterone replacement is very important. So we're talking about a male hypogonadism. That means either they have problems with the pituitary, either with the thalassemia itself, or either thalassemia complications, iron toxicity and things, either hypopituitarism, pituitary deficiency, or actually testosterone problem itself, like having the low testosterone. So it's very important because testosterone is important not only for the sexual function, but also to do with the bone density, muscle bulk, again, similar to the memory issues, stress, anxiety. So a lot of things it helps, but it can be tricky to get the right dose of testosterone and right preparation and things as well. So that's why. So it is, so we kind of manage, take some time, like a 2 to 3 sessions before, they may find, it may take a few sessions before we find the right even preparation or right dose. Okay, and also initially actually to see, so the symptoms are, they can be, it can be, they can be very symptomatic even with the low testosterone levels or high. So if I have to find out actually what's going on with them, so we check them properly first. Actually, the testing process is also very important, depending on that, whether taking the gels or injections. So we have to take test levels either fasting or appropriate timings, also very, very important to know that. If we see that either if it is low testosterone levels, so we try to improve the testosterone levels by adjusting the doses slowly. If it is high, we need to look at that, why it's got high, and whether we have to adjust the doses again. So to find, so usually with the normal testosterone levels, with the usual doses of testosterone, usually people may not have the symptoms of either with anxiety, aggression and things as well. But if even few people can be very sensitive, even with the normal or low levels of testosterone as well. So in that case, we can reduce the doses to the lowest bottom levels of the, or the doses, and then gradually we go up. So,
Okay.
at least to get some kind of a benefit. So, and then they may tolerate, people can tolerate it. Or we may change the preparation as well if that, if that particular person is on injections. So then maybe we change to a different injection, or may change it to the gel to the injection, because usually a shorter duration of injections, like we have injections two types, too broadly, like a quick acting that will last for 2 to 4 weeks, and some of them last for 10 to 12 weeks. The longer acting ones are very smooth releasing and may not have such a effect of anxiety, aggression, and things. So that means and gels again, because you have to use daily, so it can have a daily fluctuations. So it's mainly about finding the right preparation for the patient and right dose, to be honest. And also, when we activate the patients on the testosterone, we have to make sure that not much side effects going on regarding the testosterone itself, like a blood test. Again, checking the blood test to make sure that it's the right dose, no side effects. Depending on what preparation, we may check frequently, 3 months, 6 months. So there's no set protocol. It will change depending on what they're on.
Okay, so this question is kind of asking what you've just answered, but also includes a bit more. And it's, can you ask, if someone's testosterone level is low, what is the best way to increase these levels quickly? Is it via the injections or through? My screen is in a different country.
It's okay.
So I have to apologize because the technology doesn't work when you need it to. Sorry, so I'm going to say that again. What's the best way to increase levels quickly? Is it via the injections, test, or gel, or is there another alternative option?
So I think it is a similar way, but so I think what we would like is, in general, is that we don't want testosterone levels to push up so quickly, because patients might be low for some time, and suddenly increasing the testosterone to levels to the normal, they may not tolerate it, and it can cause a lot of side effects as well, as you said. It's there. So I mean, we can work. It has to be. It's not. I'm not saying that very slow, but it's reasonable pace. And so over a few weeks to a few months time, rather than within a week, they may not even tolerate it, and it may not be good as well. It is depending on, again, we can do that gently with the gels. Most commonly used preparations are gels, and injections, which is usually 3 monthly injections, like, because this gives them enough time. They don't have to work too much, because they already have, other people have blood transfusions every few weeks, and every week, every month. So a lot of things going on. We try to keep it less of bothersome of having this another problem, isn't it? So we try to combine that with either with the hematology day units. They can do that injections every 10 to 12 weeks and things. So like that, or gels, very simple. We start with a very small dose, and gradually, because there are a lot of preparations. It has to be, again, it's difficult to answer what preparations things. So, but again, it has to be reviewed by the endocrinologist, I guess. But a lot of GPs also very much, sometimes can be, if they can't find any specialized GP specialized in this. I think the hematologist, again, through the endocrinology locally, can be sorted out.
Yeah, and I think one of my kind of, when you said GPs, again, I get worried because you need to test these levels quite regularly to make sure that they're not exceedingly high or exceedingly low, and whether GPs will have access to being able to test that. So I think
it's a good idea to, I can go through us. I'm not saying, but I think it's about also having the capacity. People don't have to wait sometimes. But we all welcome. That's what ideally should be happen, and giving advice. And once we are there, give advice to the GPs may help, because not all the time people require every time. It may appear a bit strange, but once people are on the right dose of testosterone and things, we don't check often. 6 months or once a year. So that can. So maybe initially, few weeks, maybe we just need to have some communication, but we may mostly we do that, make it more easier to the patients with the help of the day units, because they have a blood test anyway, so we can do that. And after that, once we are on the right dose, they're on the right dose, it's just once a yearly or something like that, mostly.
Yeah, I think so. I think within the THAL protocol, I think they get tested every 3 months or so to
I mean, I think
test.
that is, I think it's all, that's quite, because, people, if somebody are not diagnosed with the problem, actually having low testosterone,
Yeah.
we do that with the yearly test. Somebody on the treatment, depending on the treatment with the gel and things. So the 3 months, I think it's quite arbitrary. So I'm not sure what the context is. We quite change depending on patient needs and things. Sometimes it may have to be quick. Sometimes it may have be. You don't have to be 3 months. Once they are on the treatment, believe so, we are quite happy to be managed because it won't change much.
No, I
Only we
think
repeat them when they are like we are changing the doses, but otherwise not.
okay. Yeah, because I remember we had an issue in a London hospital where I think they weren't managing the levels properly and people were being overdosed with it. So I think that's where they implemented having these scans these blood tests quite regular
Yeah,
to ensure that the levels were at that level that needed to be supplemented or what.
that's fine. I think that's why the centers all in one place, like all things probably would be better. I'm sure you can hear me.
Yeah. Sorry.
Yes. So yeah, I think it's about I think I think in next few years time, we hope what we are planning is going to work in all over the country, and we will have and again when the new guidelines come and things, so I think hopefully we all follow the similar way, and so we all get there soon, hopefully all together.
Okay, so
Fine.
I will give you a break to catch your breath, and I'm going to go
Okay.
back to Dr. Melikar to ask him some questions. So thank you so much for that. I will be back to you soon. Okay, so the next question we have here is back to on HRT and menopause treatment. And one of the questions here is it necessary to discontinue HRT, which is hormone replacement therapy, after the age of 50 due to the potential risk of cancer? And similar to the considerations with contraceptive use?
Yeah, so it's a good question. So a lot of knowledge we have about HRT, hormone replacement for menopause, comes from either women who are healthy, don't have thalassemia, or from other populations where women have had hormonal problems because of some other medical conditions. And so therefore, to be honest, for women with thalassemia, there's very little or almost no data out there. So when women are going to use HRT, say after 50, we have to often consider or extrapolate the data or the studies we have for healthy women or women with other medical condition and apply the same rules to women with thalassemia. So to answer in short, if you've got to 50 and you've been on HRT, you don't necessarily have to stop HRT. You can continue taking hormone replacement therapy for menopausal symptoms, for bones, for heart benefits, but the caveat is it has to be individualized. So some women may be particularly at a higher risk of having blood clotting problems. Then you need to adjust your HRT, maybe choose a different route like a transdermal gel or a patch than an oral route. Similarly, what we know is if you've been taking HRT for, say, hypog because your own pituitary hormones were not working, at least until the age of 50, you don't have an excess risk of breast cancer. But once you cross the age of 50, and then you start using it until 55, 60, 65, then in that sort of situation, you will have a slight small increased risk of breast cancer the longer you use the HRT after the age of 50. So a little bit of change happens. Below 50, mostly beneficial, no excess risk of breast cancer for most women. After 50, you can continue for symptom benefit, bone and heart, but a small increased risk of cancer has to be balanced. And that's why you may be advised to change your HRT slightly to different, say, body identical hormones or taking them through patch or gel. So you have to have that individualized discussion if you want to carry on with HRT, but you certainly can carry on.
Because I've heard from some of our members, and they had these discussions with their doctors, and it was what was explained to them that it was due to like financial reasons and NHS not having funding and things.
No,
Do you think that's
not
appropriate?
correct. That's not right at all.
Okay.
So women do have access to HRT in the UK. many GPs may not be willing to take the initial commencement of HRT, and that's because they may not have sufficient expertise, say in women's health or hormones, especially with the complexity of thalassaemia, which may be affecting multiple organ systems, in which case all they can do is request a referral from the GP to the nearest NHS menopause service or the nearest NHS endocrine service. Either way, whichever clinic they are referred to, they can then go through what happens to their HRT if the GP is not confident enough to start them off or continue their HRT.
Okay, and is this, because again, we have quite a very strange relationship with GPs throughout the country. Is this something that we can ask the hematology doctors to do? Can they refer
Of
to
course,
these
which is what
centers as well?
happens now.
Yeah.
I think Lakshmi was alluding to it, is that going forward, I think we want to do what Lakshmi is doing in his hospital, is GP may not have to be involved unless it's really something simple that can be done as a monitoring process. So if Lakshmi sees a patient and it's directly coming to him from hematology or any other department who thinks maybe HRT will benefit this patient, they don't have to go back to GP, wait a few months, and then come back to the endocrine clinics. Hopefully, fingers crossed, if that concept keeps spreading, we will cut down waits and unnecessary referrals for most of our women.
Okay, and then, the next question here is that it says, despite undergoing a hysterectomy at a young age, I have never received HRT despite experiencing menopause symptoms. Now I'm in my 50s, I'm considering restarting HRT due to recurring symptoms. What do you think about this?
Again, it's individualization. Giving specific advice to the person without knowing more about their medical background won't be appropriate. But as a generic advice, first of all, very sorry, because if you had hysterectomy, removal of ovaries, and you were kind of put into surgical menopause very early in your life, then you should really have been offered HRT. So that was something that was missed, I guess, unless there was a medical reason for it. Because earlier you start replacing the hormones, you prevent the damage that happens to the bones, to the heart, and then symptomatically your quality of life is much better as soon as you get your hormones back, because you've been pushed into a sudden menopause. That menopause can be quite severe. Symptoms are much more because the natural menopause gives you time. The hormones are coming down slowly. But surgical menopause is acute, and so it's much more severe and much more stronger. But now that you've had a gap, it slightly depends on why you want to go back to HRT. If, for example, you still have symptoms, yes, HRT can still be offered. But if there has been a gap, and in that gap, your conditions or long-term health has deteriorated, for example, there are cardiac issues or heart problems or existing other issues, then the kind of HRT you take, how safe it is, will have to be assessed first and then be offered to you. So it doesn't mean you can't take HRT. You can go back to HRT. You will still have some benefits for your long-term health, and symptoms will be much better. But the choice of HRT will have to be very carefully done, because you may have had lack of estrogen-related changes to your heart blood vessels, which will need to be factored in when making that benefit-risk discussion.
Okay, and you touched on like different types of HRT, but what can you remind us of what some of those options are available to people?
There are so many different types of HRTs now. So you have the estrogen, you have the progesterone, and for some women with low libido, of course, as Lakshmi said, you have testosterone. Testosterone I'll not talk about, it's mainly gels. We'll concentrate on estrogen, progesterone. Estrogen is available as oral tablets. It's available as a patch, which you can put on the side of your thigh or lower tummy. You have gels, which you can apply to your arms or your thighs. You have a spray, which you can spray on your arm. So there are 4 different ways you can take estrogen. Some of them are daily, some of them are twice a week. Progesterone can be taken again as oral tablets. It can be combined in a tablet with estrogen, or it can be taken as part of a patch, which combines estrogen, progesterone, or you can take it as a coil, a Mirena coil, which can be inserted in the womb, and it stays there for a number of years, 5 years or so. So there are different combinations you can do of estrogen, progesterone. And again, it depends on the medical history, risk of blood clotting, BMI, patient's choice, whether they are good at swallowing tablets, they would rather take 1 tablet a day, or they're actually much better using the patch because you don't have to remember to take a tablet. So many different things that kind of decide which HRT might be best for you, and you choose what you like.
I love that answer. And, one of the questions here was, how do I know I'm in the right HRT? But I think you just covered it. I think it's patient choice. You have all the options, and I think you should
Yes,
explore
just
them.
the two things to add, that is, you're on the right HRT if your symptoms are controlled. Yes, you may not have 100% symptom relief. Some symptoms may still happen, but the aim of HRT is to control most of your symptoms. So at least you feel your quality of life is better on the hormones than it's not. And the other way we monitor often is do a bone scan. So if it's for the bone protection, we'll often do a bone scan every 3-4 years. So we know that you're not dropping your bone density. Similarly, some people do, say, cholesterol levels or keep a monitor on general your cardiovascular health. If it's deteriorating, then you wonder, is the HRT actually working? But if it's remaining fine, you're doing everything lifestyle-wise, your cholesterol is remaining good, gives confidence that you're on the right HRT. So it's usually a long-term monitoring process, besides how your symptoms are controlled.
Okay, I think we've covered quite a lot of the questions for you here. And the last one that I'm going to ask you for now is, let me just find it because I've lost it. No, I've lost it. Okay, so it's here. Do you have to check your hormone levels quite regularly before having HRT treatment? And if they're normal, can you still have it? So I know you've answered this, but I'm just for the person who's asked it.
So as Lakshmi said, we don't do hormones routinely unless we have some questions in our mind. So if you're starting HRT, it's based on symptoms. If you're having perimenopausal, menopausal symptoms, we look at your clinical history. And if we feel this is certainly lack of estrogen, you can be given HRT without doing any hormone tests. And so again, monitoring, as long as we know you're absorbing your estrogen, that's the only time we may do a test. If we think you're not absorbing anything from oral or patch estrogen, but otherwise routine monitoring of hormones won't tell us much. It's your symptoms, your bone density, that is much more useful for monitoring.
Okay, and my last question to you for now is, and this is about, so this says, can we continue to be on birth control pills in our late 40s and knowing that I am going through menopause?
So birth control pills or contraceptive pills have been an alternative to HRT, especially if you start early, premature or early menopause below 40, or say for hypog, when the hormones from the pituitary are not coming in and you're in hypoestrogenic state. You can take the pill as estrogen progesterone replacement. The worry is after 35, as you go towards 40 and later, is the thrombotic risk, is that the pill can increase your chance of blood clotting. And you've got better options with HRT, which are less blood clotting prone. So the hormones tend to be more natural. They can be given through the skin rather than a pill. So it decreases or almost negates your risk of blood clotting. So more and more women move from the combined pill to the HRT. You can still have other options for contraception, the coil, the progesterone only pill, or the mini pill, and a few others like barrier methods. They may not be as effective as the combined pill, but the combination of them with the natural hormones still is probably a little bit superior than the combined pill. So if a combined pill has to be used in 40s, it comes with a few risks and maybe not the best choice. You might want to switch to natural hormones with the alternative contraception.
So one of the questions here is, if I don't want to switch to any other method but want to continue with this, can I use anticoagulants?
Well, we generally don't recommend anticoagulants only for the purpose of staying on the pill. That would be, I think, the benefits wouldn't outweigh the risks of having to go through initiating anticoagulation and then managing because somebody wants to take the oral combined pill. It would be much better for that particular individual to discuss their risk benefit and perhaps switch from maybe a different form of pill, a less combined form of pill with natural hormones. So I'd probably say they do need a specific specialist referral to the endocrine, hematology, or menopause so that they can weigh their options.
Okay, so I think that's all my questions for you for right now. I'm going to bring back Dr. Balmurray, and I've just seen this question and it's slightly worrying to me. But so this one talks about mood changes in menopause, but it says, I've been regularly taking B12, evening primrose, magnesium, iron supplements when fatigued, vitamin D and folic acid. Despite this, it says, despite this, I continue to experience many symptoms frequently. Is this approach appropriate for managing hormones? But I think this person didn't say what form of thalassemia they have, which is slightly worrying to me because they talked about taking supplements with iron. So I think you need to answer this one with caution, but I would answer it with one for people who are transfusion dependent and perhaps people who might have hemoglobin H disease.
Yeah, I mean, I echo your concerns, but I think if the diagnosis is not very clear, it's very difficult to give a appropriate and a particular advice to the person. But in general, again, if what I saw, I mean, I learned a lot actually also 3 years before that. I didn't know that a lot of thalassemia related to what actually they're going through and things. So I saw regularly people, I saw taking a vitamin C, so few people with zinc and other things. But iron, I have not seen, as I said, because either iron has to be, I mean, usually kind of monitored and also given by the help of the hematologist, I guess. So, in general, I think knowing what actually going through the diagnosis, we need to find out actually the root cause, what actually happened, what is causing it. That will probably, help, and that can actually help this particular individual can stop a lot of other things, because sometimes a lot of medications can interact themselves, or in cause itself, because we don't know sometimes what they have in actually ingredients as well. So it's very difficult for us to advise actually what they're getting is the right treatment, the first thing. So we need to find out actually the cause, and definitely need to see the GP or hematologist if it's particular there. I don't want to make them kind of a worry this moment of the time. It may be that as you know, the people with thalassemia have a lot of people have a lot of symptoms going through. So it could be just disease itself, or maybe just finding a right answer, or at least maybe reassurance of finding out, of doing appropriate investigations by the history and investigations. And if nothing is found, at least reassured. So at least that will do. So if end of the day, if they think if it is a menopause, actually, that we need to find out actually it is a menopausal symptom or not, something else. That's the thing. If nothing else is there, if it's a menopausal feature, so then that means introducing the HRT. We discuss, HRT or non-HRT preparations if people are not, as Dr. Vikram, as you mentioned. So that may help, So I think there, and this particular, people in this situation can get a lot of help, or can be going guided to to find out actually what the problem is, and can be helped.
Okay. So, and I think if you have that particular person, if you are on this call, and you get in touch with us again, we'd be able to help you find the right person to go on.
Yeah. I think it's I think a lot of it is like we all doctors are like a basic physician. Like we try to find out actually basic information, depending on actually what they say and what we examine and things. We ask appropriate tests and things. So a lot of things matters if somebody to go through whether it's a menopause or not. It can be straightforward for a lot of people, but sometimes it can be very, very challenging, tricky as well. I think is to getting the facts right are very important. Yeah, it can be done by either hematologist directly refer. They can do sometimes times. I see, a lot of things they don't even come to us because they know a lot of things the hematology can do that, because not necessarily all of them are endocrine or menopause.
Yeah, in some cases they had no choice and they had to try to go across fields. But okay.
Yeah, I know, I understand it because it can be challenging for them to know, but yeah, it needs appropriate reassurance by kind of assessment, a thorough assessment.
Okay. The next question is, I'm in my late 30s and have been prescribed 3 months of primrose oil to help manage with breast pain. What does research suggest about primrose oil?
I'm afraid I can't really answer. I don't know much. Again, maybe Vikram, if he understand, because it's out of my depth, to be honest.
So evening primrose oil or primrose oil has a weak estrogen-like action. And it's thought that the reason it might help with breast pain or tenderness is because it can sort of block the action of estrogen on breast tissue, because the evening primrose would block that. Or it would sort of confuse the breast tissue cells into using the primrose oil rather than actually the estrogen having the effect of breast pain. So a lot of women either naturally having breast pain or on HRT getting breast tenderness are told to use evening primrose oil. Scientific studies are very limited. So this is mostly comes into supplement sort of category. We tried to look for studies sometime back trying to do a write-up on this, and there was very little literature actually nicely studying whether this is really efficacious, what are the long-term safety issues. There is very little about it. Generally, it's thought to be any risk-free, so it's available over the counter. If you go to Holland and Barrett, you can purchase it. So you can try it. For some women, it works. For others, it doesn't. If you try it long enough, say at least 2 or 3 times a day for 3 to 4 months, and it does show you improvement in pain, continue. There shouldn't be any long-term risk. But if it doesn't work, then probably don't spend more money. It might not work for you.
Okay.
Thanks,
Great.
Yeah.
I think we've answered the second part of this question already, but because this is by Connie, who's in the chat, and it says, if I don't want to take pills to improve my progesterone levels, what options do I have? But I think you went through that quite with the different options of HRT. So I think that's a conversation to have with your specialist to find the right one for you. The next question is, what is the best treatment for osteoporosis?
I think I can answer that. So it is again, it's a broad topic, but it's very important, particularly taken into the thalassemia people consideration. So osteoporosis is a low bone density, bones gone weaker, isn't it? So there can be a few causes or reasons why people, particularly, why thalassemia, people with the thalassemia have got almost 2 to 3 times more risk of having a low bone density than people who doesn't have a thalassemia. So because bones depending on things, including the hormones, things. So estrogen, testosterone, a lot of other hormones, and also in thalassemia, as we know, it can affect the endocrine organs. That's pituitary, ovaries, thyroid, parathyroid. That means calcium, the glands that can control calcium things. So a lot of reasons why people, and even anemia itself, and treat some of the treatment of thalassemia thing as well. So a lot of things people can have osteoporosis. But I think when we suspect if somebody has got all these complications going on, we look for the bone density as well, because sometimes it can be underdiagnosed. So how we do that is, we can do few things. We're starting with the assessment, clinical assessment. They might have some scans already, and they may incidentally find something about the low bone density. But also we look at tests, for example, like thyroid, parathyroid, calcium, some of the blood test, which is a kind of a routine thing now that we have to do that every year. And sometimes, so if we already have these endocrine problems, if they are either in replacement or not on replacement, so when they are on adequate replacement, we don't have to worry too much about, because we are taking care of it, because bone density, they will take care of the bone density. But if there is a gap, or if there is a concern from the anxiety or the physicians, then we can check if their bone density scan, that's called DEXA scan. So we don't have to do that again very often. If somebody is definitely at risk of developing the osteoporosis or low bone density, we can do at one point. And sometimes people can come with fractures, with that back pain and things. So this was a few people, so few things can point to them that there may be something is going wrong there with the bones. So then we'll assess the bone density, and if it is low for their age or not. So, and if it is low, the treatment is actually treating the underlying cause. I think that was actually the question is for, isn't it? So not all the times we go with directly treating with the special medicines. No. So we have to treat underlying cause. That means better thalassemia control, better nutrition with the calcium and things. Treat if it is a thyroid problems there. Treat parathyroid problem. And even if people with the testosterone deficiency, if it is male, and if it is, again, HRT is very, very important, because it's like a premature, like a hypogonadism, like, so appropriate HRT. So these are the treatments. First, we have to address all the things. Despite all, if somebody is at risk of very high fracture, and then, we can discuss about, we can sometimes, if somebody had at risk of fracture or already had a fracture and other treatments are not helped, So we can give some treatments like we have tablets, we call it as bisphosphonates, or we can give something like the same thing in the infusion, but we reserve them for slightly for later in their age because they may need, because we have a limited time for them to use, because we usually give 5 to 10 years, not more than that. So we don't want to just like lose the resources early in the time. Rather, we focus on doing underlying problems. And if they're still at risk, most of the times we can see the improvement. Again, as Dr. Vikram said earlier, so we may have to repeat that bone density while we're doing that. So depending on that, anywhere between 2 to 4 years or so. If that's improving and working, that's fine. If not, then its fracture risk is going up. Then we can look at other special medications as well. But for that, we have to be carefully monitoring, because once we treat them, we have to use it for a limited number of years. And we may, once the bone density is improved, we may have to hold it up for a few years, because we don't want, and in the later in the life, again, we can restart using it, depending on how the bone density is going.
Okay, so one thing I'll say is, and this is based on like my experience in the Thal community, and I think it's part of the usual scanning from age 14, I think, to do DEXA scans on an annual or biannual basis, or every 2 years. And lots of people get diagnosed with osteopenia, osteoporosis quite young, and they are put on bisphosphonates, either IV or oral, quite young. And I can tell you about patients who have been treated for 20 years on bisphosphonates, not been told about the dental aspect, and now are losing their teeth. So I think I like the fact that there's more consideration now into when you prescribe bisphosphonates, because I think previously people were prescribed it quite young, and now they're dealing with the new things actually that our communities know how to deal with. We don't know, but it's sort of teeth and like hip necrosis and things are seeing quite a lot more of.
There are some, that's why it is, because that's why it is like the approach where hematologists working with other specialists or specialized to manage these things will help, because we train to manage bone density, when to avoid inappropriate medication if it's not required and things. And also we can carry on the investigation. So, I mean, it can be, the practice had changed. I can say that overall for the last few years and things, and more data, more evidence has come up with, what is the best practice and things. So things have moved, I guess. But yeah, I mean, I've seen few similar reports that, being, so it's difficult to comment on those individual things because we don't know what was the situation, why it was started. I mean, sometimes we have to give them bisphosphonates, these, like as you said, infusions, if it is really people are at risk of developing fractures things. So, but we wouldn't have not given, and we are more reserved, or we have got more evidence how to manage it. And also we have now clear guidelines, or even practice that to advise the patient. We have to, yeah, as you said, it's our responsibility to tell patients actually what they are going to get it and what are the side effects with it. It's very important to monitor for it and to avoid any unnecessary extra fracture, because bones can get too thick and get to fracture easily, isn't it? So we want to avoid that. So it is all about, I think, knowing the things. I think there are some strings attached to them. But I think it's once we do that, I know that the all guidelines will change with the time, and hopefully the new guidelines will get more insight into this, I guess.
Okay, and there's this last question came up about osteoporosis that just came into the chat. You mentioned that you tend to treat people for 5 to 10 years, but not longer than that. What is the longest period that you think is safe to treat people on a bisphosphonate?
It's a good question. Again, so there is no set time interval actually. If required, we may carry on with them a bit longer if it's required. So the studies and data shows that the best time, it's 5 to 10 years would be the appropriate time to avoid the side effects, to get the risks of in the long term. So it is sometimes if we have to give longer than that, we've got other preparations nowadays. The treatment has changed. We've got different type of actually, it's not necessarily this, we're talking about bisphosphonates. There is something called injections, denosumab, something. I just don't want to give anything here, I get the names, but some of the medicines can be given long term. So
Okay.
that's why I think if we get the right patient, so we will explore what are the actually risks of benefits of having treatment, what they have. If they can't have it, then so sometimes we may have to carry on with if we both agree, the patient and agree that what to keep an eye on, or we may discuss other things now, so which can be given for longer time.
Okay.
Yeah.
I'm going to ask you because I'm mindful of the time and I don't want to take too much of your time anymore. There's one more question I'm going to take, and I think the other questions that we've gotten,
Sure.
if you both agree that we can send it to you and you give us the answers, and then perhaps we could put a document together so that patients have this as a FAQ after. Is that all right?
Fine, yeah.
Yeah, but so the last question is from it is, what are the pros and cons for coming off testosterone? This is male HRT when you are trying to have children, and how long would you advise them to come off?
It's a very good question. Actually, I should have come in the first discussion, but I'll try to be as simple as possible. Okay. So it's a fertility issues will come up. So I think I would take a case, for example, like, you make it easy for this. So people, male people with the hypogonadism, that means if they have got low testosterone from either pituitary problem or testicular problem. So these are the reasons why people may need a testosterone. So if they are on that's why when we start the treatment, particularly in young group, and they can be, it is very important that they should be go on that if it's needed or they require it. But obviously there is a concern about, when they're coming to the fertility, because the testosterone treatment itself can temporarily reduce the count of the spermatozoa. That means, it won't, the long-term consequences regarding the fertility, I don't think it's maybe many, but I think so. If somebody going to the fertility, I think what we need to look at is whether there is a problem with the testis or with the pituitary. If there is a pituitary problem, not a testicular problem, they're more likely to benefit from other things. That's again we did discussion in the clinics. So something like giving the directed pituitary hormones or hypothalamic hormones, which can boost the testosterone and also improve the testosterone itself. So what we advise is, so we can if somebody is coming to the clinic with the testosterone on and they are keen on having the family starting in the next few months to year or so, so we'll agree on trying either to stop it and then starting on a different treatment. So it is like, when we stop it, they may have symptoms of testosterone deficiency. So that means it's tricky. So few people will choose to stop it completely and then see how it goes. And then I think it's probably at that time, probably we will be referring them to Vikram or the fertility clinics or things to discuss whether they got other options as well. So sometimes people are very, they don't want to stop the testosterone because there can be symptoms can be very debilitating. So we'll refer still them to the fertility clinic to discuss with them so that the fertility clinic can come discuss with the plan about if they are candidates for other treatments, whether simultaneously they can reduce the testosterone slowly and gradually start on other treatments as well. So, but it is definitely not a contraindication, but it has to be, we discuss that when we start it, so that it may take few months before they can start having their spermatozoa back, or they can still have a help from the fertility clinic.
Okay. I'm going to stop the questions here for it because we've gone over time. And I think if anybody submits any other questions, we can email it across and we can go from there. But I just want to say thank you to both of you so much. I don't know if Dr. Talukan has anything that he wants to add, but I really don't want to keep you longer than you should.
I think it was very good. Of course, Lakshmi and I have tried to cover as much as we can.
Yes.
But it's such a big area. You could talk at least 5 or 10 webinars just trying to get all the basics through. So thank you, Lakshmi. Thank you for organizing this, first of all. So UK Health Society, thank you so much, Rohana, Rumaini. And so we'll look forward to doing more with specific topics, hopefully in future, so that we can address any specific questions they have. But for the time being, if you've had questions, feel free to send to us and we'll try to get back as much as possible.
Yeah, thank you so much. It's been really helpful. And I think you're seeing some of the feedback now in the chat. But I'm so glad that you both are on board with us. We needed this. We needed you 20 years ago, but I'm glad that we have you now. So I'll be in touch.
No worries. Yeah, it's really, I'm glad that I've been invited, and thanks to Rowana and Romain, and also thanks to all the patients with the wonderful questions, and they're
Yes.
great questions. Wish we got a lot of time. We can't cover that. I agree totally with Vikram. Thanks, Vikram, again, to sharing the questions. Without you, it would have been very, very challenging for me to answer all the questions. But yeah, I'm looking forward for the future, and hopefully we all get there.
Lots more work ahead. Let's do it together.
Yeah, you do. And I think that's it. It's working together. And I think looking at the issues for patients, I think the learning from this one is that we cover andropause and menopause and things as separate topics because of how great they are and how many questions we have. But thank you again so very much. And for the other patients who have joined, I hope that this has helped. It surely helped me understand a bit about menopause and andropause, even though I'm not at that stage of my life yet. So I will say good night from us. Anybody, if you have any more questions, please send it to us. You know how to get through to Ira. But I'm going to say good night.
Thank you very much.
Bye. Bye.
Bye-bye.
Thanks, guys. Thank you.
Bye. Good night. Good night.
Thank you. It was really helpful.